less discussed in most of the meetings, maybe with the various reasons. So we have chosen this topic very precisely so that we can discuss in detail about this. Another things which we have to know about this, there are two things about the pain. One is the nociceptive pain and another is the neuropathic pain. These are the two different terminology which is used. Nociceptive pain is usually acute of short duration, and that is a protective function for the somatosensory system. Whereas a neuropathic pain is a chronic pain and it is disabling, and certainly it may be associated or may not be associated with the neurological deficit. So this is again a very important part we have to know. And for example, we can see even in certain cases, the number of the cases are very much high, like the metastasis or the multiple sclerosis or maybe the spinal cord injury. In these cases, the incidence increases or jumps to the 20 to the 80% of the cases having this problem, and that is a lifelong problem. So the treatment has to go for a very long time. On top of that, this program has been supported by the La Renon. La Renon is helping us since the last conference, and they have introduced a new molecule for this, which the doctor Praveen will be talking about all this, and then we shall discuss about that, what is the utility of that molecule. And this top we have chosen 3 firebrand speakers. One is Dr. Isha, Dr. Chris, and Dr. Praveen, and all are so that we need introductions about that, and they have presented many times and very nicely. So now I shall request Dr. Isha, and at the question and answer would be taken by Amit or the Yamroka, and then we shall have a discussion at the last. Now I shall request Dr. Isha to start her presentations about the medical management of the neuropathic pain, followed by the Krishna Sharma, and then the Praveen, and the question and answer would be at the last of the session. Thank you.
We are starting very soon. Just some small minor technical problem here. एक मिनट सबले पर्खिदिनु होला. सुनिन्छ
सुनिन्छ अलिकति टेक्निकल प्रब्लम आइराखेकोले नमस्ते सबैजनालाई
सुनिन्छ सर त्यहाँ सुन्या छ
सुनिया छ थ्यांक यू
हजुर Good evening, everybody. Neurology. Going to present. In this neurosurgical forum once again. And I would like to thank all the seniors, executive members of.
Eco Ira, sir. Eco Ira, sir.
and अब सुनिन्छ
सुनिया छ इकोइङ मात्रै भइराख्यो
डाक्टर ईशा हजुरले दुईटा सिस्टममा अडियो टर्न गर्नु भएको छैन नि एउटा सिस्टममा मात्रै अडियो अन गर्नु होला है दुईटा सिस्टम क्लोज बाइ छ र दुईटैको अडियो अन छ भने इकोइङ हुन्छ
एउटामा त थोडी
दुईटा सिस्टममा कनेक्टेड हुनुहुन्छ भने एउटा सिस्टमको अडियो चाहिँ अफ गरिदिनु होला
भिडियो पनि अन भएन शेयरै भएन यो स्लाइड त्यसले गर्दा ओके मेरोबाट some problem there is I could not share the slides so I'm using Dr. Praveen को बाटै मैले प्रेजेन्ट गर्छु Okay, I'm very sorry for the technical problems. So I'd like to start my presentation today, and I'm going to talk about neuropathic pain, a short overview and medical management. As we all know what is pain. Yeah, all of us have very much experienced pain. So pain is described as an unpleasant sensory and emotional experience, and this definition by International Association for Study of Pain has been slightly upgraded in 2018 as an unpleasant sensory and emotional throbbing, stabbing, aching, pinching, or it may be described in many other ways, and it might bring about many physical symptoms. And coming to the pain, it can be either acute pain or chronic pain, and like Professor Sultania just said, it could be nociceptive pain or it could be neuropathic pain. And just a small info about pain. Pain word has been derived from the Latin word poena and Greek poen, which means penalty or punishment from God. And as we all know, pain has been treated as a vital sign since 1999. And it is very important to know about it because it is one of the commonest symptoms in the physician's visit. I mean, in clinical visits, almost 80% of the patients present with acute. And it is said that globally around 20% adults are suffering from pain and 10% newly diagnosed with chronic pain. And data has shown that
डाक्टर ईशा यो प्रब्लम चाहिँ किन भइरहेको छ भन्दा
on our nociceptive receptors receive the pain and they are
I know.
Through these first order neurons, the electrochemical signals are transmitted to dorsal horn of spinal cord, where the voltage gated calcium channels are activated in the presynaptical terminal, which allows influx of calcium. And this calcium influx releases glutamate, excitatory neurotransmitter, into synaptic space. And this glutamate, once gets bind to NMDA receptors of second order neurons, it leads to depolarization. And these neurons cross over in the spinal canal and go up to the thalamus and synapse to the third order neurons. And these connect to the limbic system and cerebral cortex, where the pain is sensitized. And there is inhibitory pathway also working side by side with anti-nociceptive neurons, which originate in brainstem and travel down the spinal cord and synapse with certain interneurons in dorsal horn by releasing serotonin and norepinephrine. So we have excitatory and inhibitory neurotransmitters which are working together in this pain pathways. And as we all know, these pain, like I said, acute pain and chronic pain. Acute pain is usually occurs in response to tissue injury, results from activation of peripheral nerve pain receptors activation with their specific A delta and C sensory nerve fibers. And the chronic pain is related to ongoing tissue injury and presumably beta fibers as the large diameter fibers which which are active fibers, medium diameter fibers, which actually normally get activated by noxious stimuli like sharp pain. And fibers, they are small fibers which normally activated by noxious stimuli, and these are responsible for secondary pain, normally like burning, aching pains. So mechanism of pain sensation usually involves of complex interactions between peripheral nerve and central nervous system. And pain sensation is modulated by excitatory and inhibitory neurotransmitters released in response to stimuli, like I said previously. Sensation of pain is composed of 4 processes of transduction, transmission, and perception. Like number 1 is cancer-related pain. Number 2, operation or post-surgery pain, and third, final being the spinal problems. And apart from there are other causes of pain. When the patient presents with pain, the main clinical features, as we talk about, in case of acute pain, patient might be in distress, but in case of chronic pain, maybe there is no noticeable suffering. And in case of acute pain, patient might describe as sharp, dull, or shock-like symptoms, and these type of shooting in, radiating pain. And at times it is fluctuating in intensity and varying in location. And non-specific symptoms are associated usually with acute pain and also with chronic pain like anxiety, depression, insomnia, anger, fear. These type of symptoms are associated. And coming to the signs, when patient is in acute pain, patient might have raised blood pressure, patient may be tachycardic, hydrosis is there, diaphoresis is there, patient may be pale. And in case of chronic pain, and sometimes in acute cases also, there may be no obvious sign. And one thing, as we all know, pain is a very subjective feeling. It's a subjective thing, and there are no laboratory tests to diagnose pain. So pain is diagnosed based on patient's description and history alone. The types of major types of pain, there are 4 major types of pain. Nociceptive pain, typically the result of tissue. Inflammatory pain, it is because of abnormal inflammation and inappropriate response of the body's immune system. Neuropathic pain, pain caused by nerve irritation or nerve damage. And functional pain, pain without obvious origin, but patient might feel pain. So now today I'm just talking, my main focus is about neuropathic pain. So now I'm coming to neuropathic pain. So what is neuropathic pain? So neuropathic pain is defined as the pain caused by a lesion or disease affecting the somatosensory system. And neuropathic pain is a very complex chronic pain state, usually accompanied by tissue injury, and almost 35% of chronic pain patients have neuropathic pain. And it is said that around 5% of the world population is suffering of neuropathic pain, in which the data shows that around 15% of US population with chronic pain have neuropathic pain. And neuropathic pain can result from damage anywhere from peripheral nervous system, spinal or supraspinal nervous system. And neuropathic pain is a clinical diagnosis, and most of the pain are usually clinical diagnoses. And the presentation may be varied. It could be intermittent type of pain, constant pain, spontaneous pain, or provoked pain. And so neuropathic pain usually requires a systematic approach to assess, including a detailed history, physical examination, and appropriate diagnostic testing to diagnose neuropathic pain. So neuropathic pain can be peripheral neuropathic pain or central neuropathic pain. It could be peripheral neuropathic pain when the pain is initiated or caused by a primary lesion or dysfunction in the peripheral nervous system. Like, for example, diabetic neuropathy, postherpetic neuralgia, these type of pains are peripheral neuropathic pain. And it could be central neuropathic pain when the pain is initiated by a primary lesion or dysfunction in the central nervous system, like pain associated with stroke or spinal cord injury. So now coming to the neuropathic pain pathophysiology or the pain mechanism, like we all very well know about the pain pathways in the normal pain, like I just talked a few slides ago. But in case of neuropathic pain, it is very complex and it is not very clear cut like other common, normal pain pathology. But it is, there are few speculations which might cause neuropathic pain. So it could be because of the first order neurons may increase their firing if they are partially damaged and increase the number of sodium channels, which leads to chronic and persistent pain. Or at times it could be ectopic discharges, which occur as a result of enhanced depolarization at certain sites in the fiber, leading to spontaneous and movement-related pain. And sometimes the inhibitory circuits may be impaired at the level of the dorsal horn or brainstem, allowing pain impulses to travel unopposed. And sometimes maybe alterations in the central processing of pain due to chronic pain or use of some drugs. Second and third order neurons may develop a memory of pain and become sensitized. So pain is prolonged for months. So, and in addition, inflammatory process is of great significance in the development of neuropathic pain. This inflammatory process as a pathophysiology of pain is being described recently. I think I should skip this. So just to summarize the mechanism of neuropathic pain, in any condition when there is nerve damage or persistent stimulation of pain that results into rewiring of pain circuit both anatomically and biochemically, which causes spontaneous nerve stimulation, at times autonomic neuronal stimulation, or increased discharge of dorsal horn neurons, and these mechanisms lead to neuropathic pain. And it is also said that neuropathic pain also has some involvement of non-neuronal cells. Directly after peripheral nerve cells injury, there is recruitment of non-neuronal cells like mast cells. And these mast cells have intimate contact with nerve ending. And in case of trauma, these mast cells stimulate these nerve cells to perceive pain. And mast cells are non-neuronal cells and can communicate in many ways with different parts of CNS. And there, at times there could be deafferentation pain is also present in neuropathic pain. This is due to partial or complete interruption of peripheral or different neural activity, and sometimes there is sympathetically maintained pain. There could be two types of mechanism, deafferentation or sympathetically maintained pain. Deafferentation pain might be present in post-herpetic neuralgia, central pain, phantom limbs pain, pain felt in the region of an amputated body part. And these mechanisms are unknown, but involves of central neurons with lower activation thresholds and expansion of receptive fields. And at times there are sympathetically maintained pain, which depends on efferent sympathetic activity, and complex regional pains sometimes involve sympathetically maintained pain. And at times, other types of neuropathic pain may also have a sympathetically maintained component. And mechanisms probably involve abnormal sympathetic somatic nerve connections, local inflammatory changes, and changes in the spinal cord. So it is complex type of mechanisms are there. In all neuropathic pain, similar type of mechanism is not present. In case of neuropathic pain, usually the pain which persists beyond the healing period is chronic pain, and most of the neuropathic pain are chronic pain. And in this process of being chronic, there are multiple changes going on, and usually within the first 24 hours, at the site of injury, maybe peripheral nerve, dorsal root ganglia, spinal cord, or brain, many of the neuronal cells are getting activated. The non-neuronal cells get is more weeks of onset of pain. Just differentiate, just to differentiate from neuropathic pain from nociceptive pain. Nociceptive pain is usually it is sharp, worse with movement, and there is obvious tissue injury or illness. There is inflammation and physiological pain. But in case of neuropathic pain, it is not well localized. The symptom may be burning, sooting, numb, pins and needles, different type of sensory symptoms are there. And tissue injury may not be obvious. And there may, and the mechanism may be nerve injury, changes in wiring, abnormal firing, loss modulation, and different type of pathology may be involved in neuropathic pain. And coming to the major clinical findings in neuropathic pain, the clinical presentation, clinical findings in neuropathic pain might be quantitative, qualitative, or spatial. Quantitative, like the patient might have hyperesthesia, hyperalgesia, or qualitative, patient might have allodynia, paresthesia, and spatial, when there is poor localization and abnormal radiation of the pain. And these type of clinical findings are usually categorized into negative symptoms and positive symptoms. And negative symptoms are present due to deficit of somatosensory system, whereas positive symptoms are due to excessive activity of somatosensory system. Just a glimpse of positive symptoms and negative symptoms. Positive symptoms could be paroxysmal pain, superficial deep pain, paresthesias, and the signs in these patients with positive symptoms could be cold hyperalgesia, heat hyperalgesia, allodynia. And in case of negative symptoms, patient might present with hypoalgesia, and signs may be tactile hyperesthesia. I mean, loss of sensations are there. So positive sensory symptoms, it could be patient might present with spontaneous pain, allodynia, which means that pain due to stimulus which does not normally provoke pain, just touching or movement is causing pain without obvious reason. And there could be hyperalgesia, patient is feeling increased response to a stimuli, which is normally mild. There may be mild response normally with that stimuli, but patient might feel increased response. And there could be diasthesia, unpleasant abnormal sensation, where the spontaneous or evoked lacking sensation. And patient might have paresthesias, abnormal sensation that is unpleasant, where the spontaneous or evoked like tingling, buzzing, vibrating sensations, etc. Sensory symptoms usually hyposthesia. There is diminished sensitivity to stimulation to non-painful stimuli. There could be anesthesia, total loss of sensation. There could be hypoalgesia. There is diminished pain response to a normally painful stimuli. And there could be analgesia, absence of pain in response to stimulation should be painful. Now, coming to the evaluation of a patient with neuropathic pain, the patient will be presenting with a symptom of pain, and there could be history of some relevant neurological lesion or disease, and there could be pain distribution neuroanatomically possible. The pain distribution could be neuroanatomically possible. If no, then most probably it is not. The history of relevant neurological disease is there, and pain distribution is neuroanatomically possible, then it could be that possible neuropathic pain is there. And once we think it is possible neuropathic pain, the examination shows that the pain is associated with sensory signs in the same neuroanatomically plausible distribution, like patient says, then it could be okay, this is probable neuropathic pain. And confirming it with tests, like diagnostic tests, confirming a lesion of the disease of somatosensory nervous system, explaining the pain. If there is confirmatory, then it could be definite neuropathic pain. So it is possible neuropathic pain, probable neuropathic. By history, we can say it is possible neuropathic pain. By examining the patient, it could be probable neuropathic pain. And by confirming with the test, it is definitely neuropathic pain. But neuropathic pain diagnosis is really challenging because symptoms, there is difficulty in communicating and understanding the symptoms, the vague symptoms, and multiple complex mechanisms are involved in the development of neuropathic pain. So their recognition of comorbidity is very important because most of the neuropathic pain patients have multiple comorbidities associated. For this reason, we have to be very careful in approaching the patient to diagnose neuropathic pain. We should approach this 3L approach. It is said that we should look, listen, and locate. Listen to the patient, the verbal descriptors of the patient pain, question and answer the type of pain, location and everything, and then look for the symptoms or signs, sensory abnormalities, is there anything or not, and then locate nervous system lesion or abnormality if there is yes or no. So lesion, look and locate the lesion to diagnose whether it is neuropathic pain or not. So just neuropathic pain, like I said, peripheral neuropathic pain and central neuropathic pain. Peripheral neuropathic pain, like in post-singles, post-diabetes, post-chemoradio, post-surgery, sciatica pain, low back pain, post-amputation pains. And in central neuropathic pain, it could be stroke, pain associated with stroke, multiple sclerosis, spinal cord injury, trigeminal neuralgia, brain tumor, etc. And electrophysiological diagnosis of neuropathic pain we make like demyelination and axonal. That is the electrophysiological diagnosis of neuropathic pain, which is made by the electrophysiological studies. And common clinical conditions associated with neuropathic pain, like for central nervous system, which we usually encounter in our daily practice, like previous slide also has included much of this. So in the central nervous system, cortical and subcortical strokes, traumatic spinal cord injuries, syringomyelia, syringoborbia, trigeminal and glossopharyngeal neuralgias, neoplastic and other space-occupying lesions. The pain caused by these pathologies lead to central nervous system, central neuropathic pain. But in case of in case of peripheral nervous system problem, that is the peripheral neuropathic pain, nerve compressions, entrapment neuropathies, ischemic neuropathy, peripheral polyneuropathies, plexopathies, drugs, chemotherapy induced, fluoroquine induced, these drugs induced neuropathy is also common. And viral infection induced neuropathic pain we might encounter like herpes zoster, post-herpetic neuralgia. These are quite common, and also in the patients with HIV/AIDS. And again, the other commonest cause of neuropathic pain is pressure or structural problem or entrapment syndromes and compressions of the peripheral nerves. Usually entrapments in peripheral nerves in hands like carpal tunnel syndrome, tarsal tunnel syndrome, cubital tunnel syndromes, very, very common conditions. And then low back pain due to herniation of discs and radiculopathy, these are also very common. And other post-surgical and traumatic neuropathies are there, and we quite often encounter brachial plexus and plexopathy injuries leading to chronic neuropathic pain most of the times. And also post-radiotherapy pain is also very common. And at times there are inflammatory conditions which lead to neuropathic pain, like vasculitis leading to neuropathic pain, SLE-induced neuropathic pain, Sjogren's syndromes induced neuropathic pain. And other conditions causing neuropathic pain are complex regional pain syndrome, ischemic neuropathies, neuromas, multiple sclerosis, and at times brain and spinal cord lesions, and thalamic syndrome, and these. So now evaluating the patient with neuropathic syndrome, like neuropathic pain, like I said previously, that neuropathic pain or any pain, it is very difficult because it is very subjective feeling. We cannot do a laboratory test and said, okay, the patient has pain or this is this type of pain. So evaluation is very, very important. Like I said previously, 3L, listen, look, and locate. Similarly, there are few evaluation procedures like mechanical sensitivity to tactile stimuli is measured with Bonfrey hairs, pin prick we can use thermodes and vibrometers to check the vibration sensitivity and thermal pain. And beside this, it's very important to perform thorough neurological evaluation to identify the motor, sensory, and autonomic dysfunctions. And numerous questionnaires are used to distinguish neuropathic pain from nociceptive pain, which includes combination of interview questions and physical tests. So because there is no laboratory test, there are questionnaires which are used to assess the pain. So there are multiple pain assessment tools which are used, like rating scales, multidimensional scales. These type of scales are there, which are used to assess the level of pain, and also to identify which type of pain is that, which type of pain the patient is suffering. And these type of scales are, there are multiple scales. The commonly used scales are Leeds Assessment of Neuropathic Symptoms and Signs Questionnaire and Pain Detect Questionnaire. And this Pain Detect Questionnaire is particularly used for chronic back pain patients. And these questionnaires usually include multiple questions, and also a few physical tests are included in this. Just a simple universal pain assessment tool, just to assess the simply pain, patient has pain or no, or the worst pain possible. So this grading system, everybody of us know this, starting from 0 to 10, severe pain or mild pain or moderate pain. So it is quite commonly used. And regarding the investigations, now again, there is no laboratory test to diagnose pain or quantify the pain. Okay, patient has this much of pain. This is mild and moderate or severe or pain or 5 or 10. So there is no test. But most of the investigations we do for to rule out the underlying causes of the pain, especially for neuropathic pain, like blood investigations to rule out the underlying, maybe metabolic causes are there. Patient is having uncontrolled diabetes, or there is some vitamin B12 deficiency, or these type of pathologies. What is the cause of pathology? What is the cause leading to neuropathic pain? So blood investigation is focused on that. And the other test is nerve conduction test and EMG studies, the neuro electrophysiological study. And this study, this nerve conduction study is a very good measure in neuropathic pain, because using this study we can get lots of information, like we can diagnose whether it is neuropathic pain or not, and we can again categorize what type of neuropathic pain is that. It could be demyelination, axonal, whether it is in compression neuropathy, whether it is peripheral nerve compression or like that. And also most of the time we can localize the problem. If it is peripheral problem, peripheral nervous system problem, then we can localize the problem using the nerve conduction study. And other imaging studies like MRI, CT scans, especially MRI, to diagnose the underlying pathology, especially in the low back pain patients with neuropathic pain associated with lower back. We can do the MRI to see the underlying pathology. Patient has herniated disc or some other pathology. So just a few words about nerve conduction study. Like I said, the nerve conduction studies are performed to evaluate if a symptom is due to injury within the peripheral nervous system or not. And if it is there, then localize the site of the nerve injury. Not always, but most of the time we can speculate the location of the injury, whether it is spinal root, nerve plexus, peripheral nerve, neuromuscular junction, and or the muscle. For this, we have to combine the nerve conduction as well as electromyographic study, EMG also. And if we can localize the site of the injury, maybe we can assess the nature of the injury and also the severity and chronicity. And at times the pathophysiology is quite difficult, but most of the time the nature of the injury, severity and chronicity can be assessed by nerve conduction study. And most commonly we are using nerve conduction studies in the neuropathic pain associated with polyneuropathies like GVS, diabetic neuropathies, and mononeuropathies like peripheral nerve entrapments, CTS, trisotonal syndrome, radiculopathy, especially low limb radiculopathy, and then plexopathies, Becker-Brock's injuries. In these cases, nerve conduction study gives us lots of information, is very helpful to evaluate the patient with neuropathic pain. Now coming to the management of the neuropathic pain. And neuropathic pain is, however, a very difficult condition to manage, and it is very difficult to provide therapy to the patient and for complete relief. But combination of pharmacological and non-pharmacological therapies can provide almost partial relief in half of the patients and maybe complete relief in some patients. So the common management we are using is pharmacological management, non-pharmacological management. Regarding pharmacological management, as you know, most of us we are using antidepressants, antiepileptic drugs, topical anesthetics, opioids, and recently botulinum toxin injection is being used, and it shows very good result. And apart from that, non-pharmacological management, we are using psychological approaches, physical therapy, interventional modalities like spinal cord stimulation, local nerve blocks, neuroablative, neuromodulatory, and neurosurgical procedures. And these type of neuropathic pain, as it is a multifaceted entity with no specific guideline to treat, it is best managed using a multidisciplinary approach. But maybe because if a patient is having a carpal tunnel syndrome and severe pain, and we can see it is typical carpal tunnel syndrome, then maybe the neurosurgical procedure, release of the compression will um, relieve the patient forever. But in other type of neuropathic pain, that may not be possible. And in those type of patients, pain management requires ongoing evaluation, patient education, and ensuring that the patient follows up and regularly, and reassurance is very important. So the drugs used in neuropathic pain, I mean, in the pharmacological management in neuropathic pain, antiepileptics, antidepressants, like I said previously, NSAIDs, it could be oral or topical, steroids, opioids, and botulinum toxin injections. Just the few of the commonly used molecules, like among the antiepileptics, commonly we are using carbamazepine, gabapentin, lamotrigine, levetiracetam, oxcarbazepine. Among these, carbamazepine, gabapentin, oxcarbazepine, these are very much used for the trigeminal neuralgia cases and also for other neuropathic pain. And SNRIs, duloxetine, venlafaxine, and antidepressants, amitriptyline, loxapine, imipramine. These all the molecules are being used, and in some cases opioids are also used. And yes, many times we use topical applications of capsaicin, ketamine, gel, lidocaine patch. These type of agents are also used to combat the pain. And now the recent concept is that the interaction between the nervous system and the immune system plays a pivotal role in pain processing. Like I previously said, that non-neuronal cells are also as important as neural cells, which to elicit or reduce intensity of pain, especially in case where pain persists for long durations, as in neuropathic pain. So not just neuronal cells, but non-neuronal cells are also playing important role in the pain. So the new concept is that controlling the non-neuronal cells and controlling the inflammatory pathways, the pain cascade can be reduced and effectively block or reduce the neuropathic pain. So the concept is to stop excessive inflammation and stop neuropathic pain. So in this regard, recently palmitoyl ethanolamide, PEA, a fatty acid amide, which is found in human body, which restores balance to excessive inflammation, has been available in pharmacological form recently, and which is said to counter the activation of the innate immune response, resulting in decreased inflammation and hence decrease in pain due to excessive inflammation. So this is the new concept, the new molecule which is being available recently. So with this, I would like to end my presentation here. Thank you very much. I'm sorry once again for some technical issues initially. Thank you, sir. Thank you very much.
Hello.
Azur,
thank you. Thank you, Dr. Issa, for your excellent and detailed presentation on the management of, medical management of the neuropathic pain. Due to the time constraints, we will take the questions at the end.
Yeah, okay, please.
Request Dr. Krishna Sharma, our president of NISON, to give his talk on the surgical management of neuropathic pain. Dr. Krishna Sharma, please.
Yes, thank you.
Hello.
I have to share my screen. Can we see the screen? Can we see the screen?
Not yet.
I'm sharing the screen. Okay.
Yes, seeing.
You're seeing.
We can see that.
Okay. Yeah. Good evening. Without much of time, I'll directly would like to start my talk. Okay. The topic I was not sure what to talk about. So in peripheral neuropathy, I've taken a very specific topic, entrapment neuropathy, as the topic of my talk. That involves surgery, basically. So it's not moving. Okay. Entrapment neuropathy, Dr. Isha has already talked about it. Peripheral nerves are the ones that connect the central nervous system with motor, sensory, somatic, and visceral and organs. And this injury results from either compression by external forces or by nearby anatomic structures. The mechanism can vary from one or two significant compressive insults to many localized, repetitive, mild compression. Certain nerves are particularly vulnerable by virtue of their superficial location, their fixed position, traversing or a confined space, or in proximity of a joint. Peripheral nerve is subjected to repetitive movement in a very constricted space or a fibro-osseous tunnel. Usually occurs as they pass besides a joint, such as elbow, wrist, hip, or only occasionally elsewhere in the body. So this repetitive motion is a major factor that precipitates entrapment in an anatomically constricted segment. And conservative treatment involves reducing the movement and inflammation, whereas surgical treatment enlarges the space. So the basic mechanism is there is a static compression or a dynamic compression. So in a static compression, there is a wall that is enclosed, whereas in dynamic compression, the content of the tunnel becomes large or hypertrophic, like in tenosynovitis. So there could be an acute compression, there could be a chronic compression, and this could be an ischemia related, which is quite controversial. Now, depending on the degree, rate, and the duration of the compression, this could be mild and a brief compression or a sustained compression over a long period of time, causing structural changes. Not all the components of the nerves are equally susceptible. If a nerve has got a thicker layer of epineurium, the damage is less, like a cushion effect it gives. And if the neural structure is larger, it can cause a damage a little early. Now, the effect of the compression is first it causes venous obstruction, then causes arterial obstruction, then finally an exoplasmic flow. So there's a direct mechanical compression as well as the edema caused by the obstruction of the flow that causes the nerve injury. So it can account into an acute and a chronic or a combination of the two. There are different entrapment syndromes described from neck to foot, but we cannot go detail about all. And I would like to concentrate on a few very common one. And out of that, carpal tunnel syndrome is the most common. And sometimes one can have more than one entrapment neuropathies in a particular time. Now, median nerve entrapment, as I told you, is the most common, and it could be the most common sites are either the pronator teres muscle or by a transverse carpal ligament at the wrist. Now, the pronator teres syndrome, there are again three sites which I've enumerated here. The mechanism is either a direct and indirect trauma or an external pressure, which is called a Hunman paralysis, or long-standing compression of the main trunk. The presentation is vague, aching, and easily fatiguing pain of the forearm muscles and a weak grip. And there is no nocturnal exacerbation, which is very, very typical of a carpal tunnel syndrome. And the treatment is usually rest, and surgical decompression can be done when the rest conservative management is not working. Now, carpal tunnel syndrome is the most common entrapment neuropathy and is the most common cause of musculoskeletal symptoms in the hand. The compression of the distal median nerve within the carpal tunnel by the transverse carpal ligament is seen. In these patients, the it is found that congenitally they tend to have a smaller carpal canals. It is more common in ladies and in middle, and sometimes it is found to be worse in the dominant hand. So it is a very important cause for a loss of work at workplace productivity. And the prevalence is said to be around 0.7,000, and it's caused by the compression of the median nerve under the transverse ligament. Now the symptoms is like hand falling asleep, like it's a numbness, especially at night. And there's of course a numbness, tingling, burning along this distribution of the median nerve. And when it is more severe, even the daytime activities are restricted, which is characterized by, let's say, you can't hold a book or a newspaper for long. Driving a car is difficult. Holding a telephone receiver and brushing hair is difficult. Now, weakness and atrophy of the thinner muscles are seen very clearly in this one, and I will not go to the details of the disturbance, which we can see, we all know about it. And tinel sign is a very sensitive, almost 60%, whereas final sign is even more sensitive, 80%. And ischemic test is also been, when you put around a blood pressure cuff and inflate in 30 seconds, it can reproduce the pain. Now, the effect of this carpal tunnel syndrome is the quality of life, where it disrupts sleeps, as well as it disrupts doing a very fine work or manipulations. So activity of daily living may also be affected. There are many factors that are contributed to this carpal tunnel syndrome. I can't go into detail of this, but there are a few factors by the studies. There's a strong evidence of a BMI and repetitive actions at the wrist, which are supposed to be the risk factors. There are some moderate evidence, and there are some limited evidence, which I will not go into detail. However, physical activity and exercise associated with a decrease. So very aggressive exercise reduces the chance of carpal tunnel syndrome, whereas oral contraceptives, female hormones replacement is not associated with any increase or decreased risk. And there's a limited, however, evidence that any race, ethnicity, or a female education, these do not affect the symptom. Now, in the ulnar nerve, which is quite commonly we see, and the most common site is either cubital or a simple ulnar nerve decompression is required, like anterior subcutaneous transposition of the technique. Now, again, the radial nerve at the radial groove, especially when there's a fracture of the humerus, there's a weakness of the wrist and finger extension, which we commonly call a wrist drop. Now, the suprascapular nerve entrapment is quite common, but we don't recognize it that well. Where there's a suprascapular nerve entrapped below the transverse scapular ligament, and the presentation is usually the weakness and atrophy of the infra and the supraspinatus muscles. And the treatment, there are differential diagnosis, because it is quite common, but it is not very commonly detected. And the treatment initially is conservative, whereas later on the transverse scapular ligament has to be excised. The myalgia paresthetica is a very common symptom, though a very benign pathology. Just sensory involvement is there, but it is very bothersome. So the treatment usually it occurs more in a sitting or in obese patient, tight belt wearing, standing, walking, or in obese patients. And the treatment usually is sitting or lying position, L2 nerve stimulation, decompression. However, when there is it's not responding, they can undergo neurolysis or neurectomy, but it will leave a permanent numbness on the lateral side of the thigh. The other one is the tibial nerve entrapment, which we usually call it the tarsal tunnel syndrome, which occurs can occur following a fracture of the ankle dislocation or arthritis or even by a tumor. And we have to be careful that in this particular one, the heel of the foot is spared. That would be a sign to look for it and find out. And the treatment is external ankle support or surgical decompression where the flexor retinaculum is divided. Now, in short, the diagnosis can be made by the history, the presenting symptom, the clinical examination, other associated problem or risk factors being ruled out or ruled in. Electrodiagnostic test can help, and finally, in some cases, imaging. Now, however, there is no consensus supporting any single diagnostic tool as a reference standard. There are many ones that have been usually done. It has been mentioned Carr's hand diagram, but I've never used it. So is the carpal tunnel syndrome symptoms. The 6 symptoms, the scoring one gives you a high probability of being a carpal tunnel syndrome. Now, the most of the talk that follows now is basically in view of the carpal syndrome because it is most common and there are a lot of studies being done, a lot of papers being written. So most of the data I'm presenting, the talk I'm giving is related to the carpal tunnel syndrome. So the electrodiagnostic study is one of the very important diagnostic tool we have, which tells us the integrity and the function of the nerve, but does not tell us the etiology. So Dr. Issa also has talked about it. It's essential tool. It localizes the site, distincts between the other conduction block and the other axonal degeneration. It has got a prognostic information because if it is the nerve itself is damaged, the surgical decompression will not help. So, but however, it is depends on the skill of the examiner and has to be augmented by physical examination. Earliest and the most significant finding is the prolonged sensory and latency, and is the most sensitive parameter in the nerve conduction study. You can check the sensory work response, motor latency abnormalities, and needle electromyography also. Electromyography usually tells us about the muscle status. Now, the guidelines from the American Association of Neuromuscular and Electrodiagnostic Medicine is that if we adhere to the guidelines, the sensitivity of this test is up to 85% and the specificity is 95%. So it is very, very helpful in diagnosing the peripheral neuropathy and helping us whether a surgical intervention is required or not, or helps or not, as well as the prognosis that follows after that. It can also categorize the compression into mild, moderate, and severe. When there is a prolonged median nerve sensory latencies with normal motor studies is mild. When there is a prolonged of a motor distal latency, it is moderate. And when there's evidence of axonal loss, it is called severe. These are the few, this is the table which is the data about it. So additional comparison studies have been done, and EMG also can help, but with a severe end-stage carpal tunnel syndrome, sensory and the motor potential may not be recordable, and EMG is not helpful in localizing, and in these cases, that means the prognosis is very bad. Now, there are some lab tests. Basically, it is to rule out the other secondary causes like thyroid, the anemia, chronic renal failure, diabetes, multiple myeloma, etc. Now, if you come to the management, there is a strong, there are evidences have been categorized. The level of evidences have been categorized for different types of conservative management. So I'll enumerate one by one. Immobilization before the surgery while on the conservative management has shown a strong evidence that it improves the outcome. It elevates symptoms, and but however, the relapse is very common. So it does not, the person cannot go back to work by immobilization alone. The steroid injections improve the reported outcome. There's also very strong evidence on that. However, magnetic therapy does not work. There's a moderate evidence on oral steroids, could improve the patient outcomes. And ketoprofen phonophoresis, that is, you apply ultrasound with a topical medication, that also helps. There is no benefit, there's a moderate evidence of no benefit on oral treatment like diuretic, gabapentin, and others compared to a placebo. Now, there's a limited evidence that the therapeutic ultrasound may help, and laser therapy, also there's a very limited evidence that it helps. Now, in the intervention, we have basically 3 injections: open decompression and endoscopic decompression. Steroid injections, the symptoms improve in more than 75% of the cases, but however, in almost 1/3, it relapses within 15 months. Repeated injections are possible, but most of the clinicians do not go beyond 3 per year. And you can either use hydrocortisone or methylprednisolone, and they avoid local anesthetics because this may mask the intraneural injection where you may cause neural damage, but you will not know because there is a local anesthetic. Now, to avoid the median nerve such a damage, you have to be very careful. You have to inject it in the line with the 4th digit. Now, the risk factor for recurrence after a steroid injection is a severe electrodiagnostic abnormality.
I think Vishnu sir is having some problem with internet. Hello, Pawan sir.
Yes, Peter. आएन केही पनि
Internet
सुन्दैन
आएन
के
के गर्ने
गर्ने
एकछिन
त
गर्ने कि डक्टर प्रवीणको प्रेजेन्टेसन आयो लास्ट
आयो हजुर?
आयो
ए सरी है, मेरो नेटको प्रब्लम होला। कहाँसम्म सुन्नु भएको थियो? यो इन्जेक्सन्स आयो? Okay, thank you. Right, okay. So, right, indication of more than भयो? Okay, thank you. So, sorry for the disturbance. Okay, there is not sufficient evidence that even in a diabetes patient, the prognosis can be good, like the symptoms can still reverse. So even there is a coexisting reticulopathy, hypothyroidism, polyneuropathy, pregnancy, or all of this, okay, we can still do surgery. Even in presence of diabetes, the results can be quite good. During surgery, I just want to highlight a few anatomical detail. We make a, if you can concentrate on this diagram, this is the line of incision, which is little medial than the midline. We start a centimeter line. The distal limit is by a line which is called a line, which starts from the base of the hook up. So beyond that, chance of damaging to this arterial arcade, causing a vascular injury. So if we can confine our incision to this limit and a little ulnar side, so we will be sparing the cutaneous nerve, we'll be sparing the arterial arcade, and we'll be directly, and if we follow the palmaris longus, then we can, which just sits over the median nerve, we can directly find the median nerve. Now, the surgical procedure, either neurolysis, is a decompression of the median nerve at the wrist, which has got almost 70% satisfaction rate. The surgical technique which I've just talked about, there can be an endoscopic technique using a single or a dual incision. I have no experience with the endoscopic technique, only a theoretical one. I'm sure some of us in the audience can help us to gain some light on that. However, there is no consensus on superiority of any one technique over the other. The surgical step, I don't want to go into detail. I just talked about the incision. The location of the median nerve has to be known beforehand by the surface marking. The option is little curve towards the ulnar side to facilitate retraction, and the flexor retinaculum has to be incised totally. It's very important to make sure that you have completely cut the flexor retinaculum, and the chance of missing out the flexor retinaculum being cut is distally, because we fear the arterial arcade, and if we leave a little bit of flexor retinaculum, that may not cause a total relief to the patient. So a complete division of the transverse carpal ligament and distal to the wrist is very, very important. In a very selected cases, the epineurium may need to be opened. However, this should be avoided as much as possible. The median nerve should not be cut, no matter how swollen the nerve might be. And it should be, if you open the epineurium, it has to be closed. And finally, the skin edges should be closed, and the flexor, the ligament should not be closed. The ligament, the flexor, the transverse carpal ligament should not be closed. It should be remain open. Otherwise, you will recreate the compression again. So there is a strong evidence that the surgical treatment have a greater treatment benefit at 6 to 12 months as compared to splinting or any analgesic or a steroid injection. The surgical release of the transverse carpal ligament relieves symptom and improve the function, relief of daytime and the nocturnal paresthesia, and return of the grip strength. There's a moderate evidence there is no benefit to routine inclusion of the following adjunctive techniques like epineurotomy, neurolysis, flexor tenosinoectomy, or lengthening or reconstruction of the flexor retinaculum. These procedures do not add any benefit to the decompression procedure. And there's a very limited evidence that endoscopic procedure is any superior. However, in the short term, the endoscopic procedure, I'll come to that later on. Now, there's a limited evidence that sometimes there might be a bilateral problem. So either bilateral or stage, it does not make any difference. And which side to do depends on which side is more painful. And when you have both the hands which are not functional, we first operate on the one which has got a little better function. And there's a little evidence that the local anesthesia, we do it under local anesthesia, or in general, so the overall outcome has not made any difference. And the local analgesic that are used, if there is something called a buffered lidocaine, where the pH is made to near neutral by adding sodium bicarbonate, which reduces the pain, which the pain control is better. However, there is moderate evidence that it has got a long-term benefit. Now, there's a limited evidence that the aspirin can be continued perioperatively. So there is no increased incidence of hematoma in the perioperative period. There's a limited evidence that there is no benefit for routine use of prophylactic antibiotic, as it is, if you do it very meticulously, it does not increase the infection at the surgical site. However, there is a strong evidence that post-operative immobilization does not help. So after the surgery, you should freely allow the patient to move the wrist. The endoscopic carpal tunnel release can relieve the symptom, and the patient can go back to work earlier. And however, the long-term outcome, the short-term outcome is better. However, the long-term outcome is equivocal to the mini open release. Now, post-operatively, whether we should do any electrodiagnostic test to see whether the nerve is totally compressed or not. We can do it after 3 to 6 months if you wish. If there is a problem, if there is a the pain does not go or does not go completely, or you suspect something is wrong, and it can be done if. However, we have to remember the symptoms continue to improve till up to 2 years. The electrophysiological abnormalities may improve, but may not return to normal range of what it was before, even with the clinical improvement. So there might be some latency in the electrodiagnostic report, even after the complete release of the compression. And it is quite useful to assess if you want in the pre and the post-operative period. There are no guidelines or standard recommendation for when to obtain a post-operative studies for surgical failures, actually, but usually they recommend to wait till 3 to 6 months. And if the repeat nerve conduction studies so worse, or if the EMG needle examination has finding of denervation, then probably you have to repeat go in again and repeat the surgery and decompress the nerve. And pre-operatively, if no such report is available, you can repeat it at an interval of 3 months and see the progression. Prolonged latencies alone are not an indication for reoperation. Now, the complication of, though it is a small, very, very common surgery, there are a lot of complications related to this procedure. The most common being pain. It could be due to a neuroma formation, or it could be, there can be recurrent thinner branch median nerve. There is injury to the thinner branch, which supplies to the base of the thumb. So it is called $1 million nerve. It is a very small cutaneous nerve. But if it is damaged during the incision, skin incision, if your incision is more lateral, so it is always better to go little medial than lateral while you're making an skin incision. And if this nerve is damaged during the carpal tunnel surgery, to lead to loss of function of the thumb, a possible malpractice suit. An anomaly, there might be an anomaly which may cause nerve to lie above or to pierce the transverse carpal ligament. You have to be careful. So it's always safe to stay on the ulnar side of the midline. You can have a direct injury to the median nerve. There might be a volar displacement and entrapment of the median nerve in a healing edge of the ligament. You may form a hypertrophic scar, which is quite common in that area, and there might be a recompression of the median nerve. If there is a failure to improve the symptoms, what are the probabilities? The first probability is incorrect diagnosis. So it is very, very important to really assess the clinical symptoms, rule out the other pathologies, rule out the other metabolic problem, so that to make sure that the mere compression of the median nerve is the real cause of the symptoms of the patient, and that is supported by the AMG or the nerve conduction study. So if the diagnosis is incorrect, you may end up with no improvement after the surgery, and that is a lot of problem. When there is an incomplete transection of the transverse carpal ligament, this is also a very common, the most common cause of failure if after the incorrect diagnosis. So you have to make sure, look at it again to make sure that the transection is complete. One of the limitations for endoscopic release of the transverse carpal ligament is the incomplete transection of the ligament, because sometimes you don't see, but I think those people who do this endoscopic procedure will not agree with me. This is what is written in the book. Now, there's a possibility of accessory ligament also. So you have to, that may cause recurrence of the pain or a persistence of the pain, which has to be looked for and cut. Postoperatively, if the mobilization is not done early, hello?
Please hasten up. Time shortage भइरहेको छ त्यहाँबाट
सक्न आँट्यो सर, सक्न आँट्यो. The joint stiffness and injury. There can be a complex regional pain. There can be infection and a hematoma. So when there's a treatment failure, the new symptoms occur or the symptoms persist. That occurs immediately post-op. There's a persistent symptom. There is recurrent symptoms. We have to look after the etiologies, and there is less than satisfactory outcomes. So 75 to 90% of the symptoms are improved. It's a very successful surgery. 70 to 90% are free of the nocturnal pain. And finally, I'd just like to conclude with the recommendation. There's a non-surgical treatment is an option for early carpal tunnel syndrome. Surgery is an option when there is evidence of median nerve decompression, denervation. A second non-surgical treatment or surgery is recommended when initial non-surgical treatment fails after 2 to 7 weeks. Local steroid injection or splinting is recommended prior to the treatment surgery, not after. And oral steroid or ultrasound also are options. Thank you very much.
Thank you, sir, for your excellent presentation. Without any further delay, can we go to our next speaker, Dr. Praveen, please? Sorry, sir. कौन sir? मैं बोल दी.
No, it's all right.
Hazur, मैले screen share गरेँ. Probably everybody can see this screen sharing. So thank you very much, Pawan sir. Thank you very much, Dr. Roka, I am Roka, for giving me this opportunity. Well, since we are running out of time, probably I am skipping few of the slides here. My topic is today is recent development, but it's a vast topic, and I'm trying to focus today only on this molecule palmitoyl PEA, which is one of the recent development, but it's recent for the Nepal actually. In fact, it has been quite commonly used for last so many, not only years, decades in European and American countries, but for Nepal, this is a new molecule. So we should say this is a recent development for Nepal. Well, I'm going to skip these few slides, which are just recapitulation of basic pathophysiology of neuropathic pain. I'm going to skip this because of this shortage of the time. This is today's topic proper, palmitoyl ethylamide PEA, the molecule, relatively newer molecule to Nepal. Actually, this PEA, palmitoyl ethylamide, is a fatty acid amide which controls the excessive inflammation. So it is a naturally occurring compound. It's a naturally locally available compound in the different organs and tissues of human body. So it is also called naturally occurring painkiller or naturally occurring anti-inflammatory agent. So it was first identified in 1952, and since then it has been undergoing multiple series of studies regarding various aspects of this PEA, this molecule. And it became more popular after 93-96 when Professor Rita Levi-Montalcini, we'll talk briefly about this this popular scientist in a while. So this molecule became popular after this study, and Professor Montalcini identified the anti-inflammatory and analgesic property of PEA, palmitoyl ethylamide. and it has been found to be having very less, minimal side effects with minimal drug interaction with others. And so far, many people have been benefited by this molecule. Well, in Nepal, it is available as palmizase. Probably many of us know about this molecule, this product, and many of us have been using this since last 1 or 2 years, I think. Palmizase contains palmitoyl PEA along with genistein and diadesin. It is available in Nepal as a nutraceutical product, that means as a dietary supplement and food additive, and it is produced by Laridan. These are a few other products that is available in the market in Europe and America. Especially this palmitoyl is very popular in Netherlands, and this is palm fruit, which is thought to be a very good source of PEA. This palm fruit, and in Netherlands it's available as Mirica. This is a brand name there, and another brand name P-Cure is the one which is available in USA. This lady, Professor Rita Levi-Montalcini, this is a Nobel Prize winner in 1986. She was awarded a Nobel Prize for discovery on neuro growth factor in 1986. She is an Italian. Since then, she has been known as a neurobiologist. She was born in April 1999 and she passed away in December 2012. So she was the first Nobel laureate who survived more than 100 years. After that, probably few others survived more than 100 years. She is supposed to be the first one who survived more than 100 years. For example, mast cells in the pain and pain management. And she also identified and discovered the role of palmitoyl in the management of neuropathic pain. So the mechanism of action of this PA, both PA became more popular and even the role of this PA. There is one enzyme called fatty acid amide hydrolase. This is the metabolizes palmitoyl PEA into palmitic acid and ethanamide. So because of this FAS, PEA gets metabolized and degraded. So there are certain other compounds as well which inhibits this FAS, this enzyme. So after the inhibition of AAS by certain compounds, the endogenous level of PEA becomes more. So more PEA available for they are also natural products. They are also locally available, locally occurring products, compounds in human organs and tissues, and these are the FAS inhibitors. So these genistein and diadesin, they increase the endogenous level of PEA and thus enhances the action or function of PEA. So palmitoyl contains all these 300 mg of PEA, 50 mg of genistein, and 4 mg of diadesin. So regarding its mode of action, how it works, it acts by stopping the activation of mast cells. It also binds to peroxisome proliferator activator receptor alpha, PPAR alpha, and thus it inhibits the release of cytokines and prostaglandins. The binding with PPAR further enhances the activity of GABA. As you know, GABA is the inhibitory transmitter. So when there is positive activation of GABA, the reduction of the pain. So this is another mode of action of PEA. And it also stabilizes glial cells and controls glial cells. There are many studies about PEA. This is one of them. This meta-analysis says that PEA is a special food for medical purpose. So they did extensive study on PEA, and this is what they found. This is a case control study. This red is the group treated with PEA for the neuropathic pain, and blue one is the control group. And they found there is significant difference in relief of pain relief between these two groups. There are many others, many studies about PEA. I'm not going in detail about all the studies, but all the studies shows that PEA is beneficial in the management of neuropathic pain. So to conclude, PEA is effective and helpful in different types of neuropathic pain, not only neuropathic pain, but other chronic type of pain. PEA-induced pain relief is progressive. It is not dependent on age and gender, and it is also not related to any etiopathogenesis of the chronic pain. So irrespective of the etiopathogenesis, whatever the cause of the pain may be, this PEA is found to be helpful. It has minimal adverse effects. It has minimal drug interaction with other pharmacological products. It is regarded as food for a special medical purpose, and usual dosage is 300 to 60 milligram per day, single or divided doses several times for several months. It can also be given higher dose for first 7 days or 10 days, then slowly taper off BD dose and then a single dose for 2 or 3 months. In that way, it becomes more effective. So I think this is the end of my presentation and end of today's presentation. Thank you very much. Thank you. Thank you, sir.
Thank you, Praveen. Roka, पहिला क्वेशन भएपछि लास्टमा चाहिँ कन्क्लुड गरेको राम्रो क्वेशन आन्सर सुरु गर्दिनु
हजुर
क्वेशन आन्सर के क्वेशन्स आयो त्यो पहिला क्वेशन्सको त्यो हेर्नुस् नि क्वेशन्स कमेन्ट के छ त्यो पहिला फ्लोर गर्नुस् नि
comments here, 2 by Narendra and 1 by Samir. So Narendra's first comment is
उलाई पहिला सक्न देऊ न यो अमितले के नेसन के
ओके ओके हुन्छ हुन्छ
त्यो पार्ट पहिला सक्न दिनुस् नि
सर त्यो लास्टमा गर्ने हो सर त्यो लास्टमा गर्ने हो
त्यो लास्टमा गर्ने हो
हजुर पहिला क्वेशन आन्सर पछि सर
ल त पहिला क्वेशन आन्सर सुरु गर्दिनुस् त रोका के क्वेशन छ भन्नुस् त
So actually, question one, there are 2 or 3 comments. The first is by Dr. Narendra, and his comment actually is a bit confusing. He's saying a post-op relative pain, compression are relieved, and the use of GABA may be detrimental, I think, to nerve revival. I think he's asking whether post-op nerve compression, if is relieved by gabapentin, then should surgery be done or not, if I'm not wrong.
No, I'm not clear. Post?
Hello, Dr. Narendra.
He wants to use gabapentin post-op or pre-op?
Post-op nerve compression.
Post-op nerve compression. And if the gabapentin is useful, then what to do?
I think so.
He said it is detrimental, not revival. Well, I don't think GABA has any detrimental effect of human body or any neuronal structure of human body. I don't know, but definitely pre-operatively or post-operatively, GABA is definitely helpful. Even post-operatively, so I personally, in my practice, I use gabapentin after surgery. So I don't know exactly, but gabapentin or GABA, what it means, I don't know, but it is helpful whether it is pre-operative or post-operative condition, I think.
Next question.
Okay, thank you, Dr. Pratik. Next question is also by him. Narendra, he says that acupuncture is a stimulator and GABA is a depressor.
Yes, anybody?
I think what he wants to say is that acupuncture is stimulators of the nerves, but they could be acting by giving or releasing the depressors, which can lead to reduced pain.
But as far as I know, acupuncture is being tried, but acupuncture actually endogenous opioids चाहिँ release गराउँछ. त्यो opioids release गराएको हुनाले चाहिँ help गर्छ neuropathic pain मा, but the long term result is not very effective. It has been seen. The another thing is the people also talk about vibration. Vibrations को बारेमा पनि is the same thing, but it doesn't have a long term effect चाहिने अहिलेसम्मको स्टडीले त्यही देखाएको छ.
Okay, thank you, sir. So that final one of the final questions is by Dr. Samir, and he has asked 2 queries. One is that I think when Dr. Krishna Sharma was presenting on carpal tunnel syndrome, he has said that acupuncture, he has sent some patients to acupuncture and they are getting quite better. And the next question is, he's asking whether any of us have any experience on ulnar nerve transposition. So Dr. Praveen or Dr. Krishna sir, can you please give comments?
Krishna will tell.
Yeah, ulnar transposition could be subcutaneous or submuscular, usually done at the ulnar groove. So I think it's quite a common procedure that's been done when the patient have got clinical features of ulnar nerve entrapment at the elbow. So I think it's quite a common and very effective procedure. It can be done, yes.
I also think so. I also think our
Line 1,
transport
2, line
routine.
403.
It is a routine procedure, I think. So everybody of us have been doing the same. I also do transposition in almost all the cases. Without transposition, I
Line
do
2,
not
line
finish my surgery. So it's a good
1,
surgical procedure.
2, 403.
And what are the experience of acupuncture in carpal tunnel syndrome? I think that's Samir's query.
Acupuncture is definitely helpful as this is regarded as a stimulatory function. Acupuncture has a stimulative function for the nerves. In that sense, definitely, I think. Well, I don't know exactly, but I think acupuncture is beneficial for any sort of neuropathy, maybe compressive neuropathy or some sort of other sorts of neuropathy. But definitely, acupuncture may be a temporary measure of temporary mode of treatment. It cannot give long lasting or permanent relief. So ultimately we have to go for surgery if there is severe compression. So in the beginning, maybe I don't have personally any experience of referring patient of ulnar nerve compression to the acupuncture. But if anybody undergoes acupuncture for ulnar nerve compression or median nerve compression, maybe initially they may have some benefit. I guess.
Okay, thank you. Dr. Samir, can you please elaborate on what's your experience of using acupuncture in carpal tunnel syndrome? Hello, Samir.
We often send patient for acupuncture and we have seen a quite good result. अब mechanism also अलि भने जस्तै stimulation होला pointer हुन्छ नि stimulating pointer लाई होला जस्तो लाग्छ what we do is we give steroids for sometimes and then if they are fine with that, some 50% of patients go good with steroids. And some of the patients who denies surgery, we send for acupuncture, and there are some quite good benefit.
How long does it do? That's the question.
I think Dr. Jia Gopal sir is the one who is having the maximum number of carpal tunnel surgeries. He has published article.
What about the acupuncture? What is the long-term results of the acupuncture? Carpal tunnel syndrome is a very common surgery that all of us do. But what about the acupuncture? I don't have any experience of the acupuncture. Till now, I have not sent any patient to the acupuncture. Till now.
We have acupuncture department in our hospital.
Huh?
We have acupuncture department in our hospital, so there are quite benefit. Patients are benefited with this. Some neuropathic pain and all, they get good benefit.
Thank you. Dr. Samir, there is a last question from Dr. Chandra. He's asking, what are the drugs which can be used in thalamic syndromes? Dr. Isha, can you please comment on this? Hello, Dr. Isha? Or Dr. Praveen, please.
I'm sorry. So in thalamic syndrome, most of the patients, they respond very well to gabapentin. Gabapentin is drug of choice actually. And apart from that, other antiepileptic drugs, especially carbamazepine. And recently, I do use duloxetine. It also gives good result. And most of the cases, gabapentin and pregabalin is the drug of choice in case of thalamic syndrome.
Thank you very much, Dr. Isa. I think there are no more queries. So I would like to Dr. Pawan sir to kindly conclude this session and hand over to Dr. Amit for his question answer session. Pawan sir, please.
Yeah. Thank you. It has been a very good session for all of us. And certainly, we have gone in the depth of the neuropathic pain. The few points which has been missed over here, that is, one is the complex regional pain syndrome, which has been a new entity, not a new entity, but it is described in the literature. So previously, Causalgia pain or Sudex atrophy. So there is a long list of that, which has been included under the complex regional pain syndrome. And because there are so many entities in that, and they are type 1 and type 2. Type 1 is a diffuse one, where we cannot localize the things. And type 2 is the localized. When we know the anatomy and it is localized, then it is called, but as far as the management is concerned, is the same. That is one. As far as the prognosis of the neuropathic pain is concerned, one of the studies showing that even after the 5.5 years of the treatment, the 62% of the patients do have the persistence of the symptoms. So it is a long-term treatment which one has to consider, because there is no cure in the neuropathic pain. That is what. And in the surgical part, more focus was on the carpal tunnel syndrome. But beside that, there are decompressive surgery that we are doing day and night for the hernial disc, that is there. And for the compressive nerves, decompression is the best. Wherever it is, decompression, it gives a good result. On top of that, there is ablative surgery also. So ablative surgery, there are many types there. The DREG is there, all the or the mesencephalotomy is there, or the thalamic is there, but none is working very well and none is being practiced also. It is all the descriptions which a student has to go through. But for one thing, ablative surgery is quite good for the Morton's neuralgia in the distal plantar nerve, where it is being effective, where the neurectomy is done. And I have experience of a neurectomy, I mean maxillary neurectomy, for the old patient in the trigeminal neuralgia, where we did that. Of course, the sensation was not there. The patients benefited very much. And beside that, the ganglion ablation by the chemicals and radio frequency is there. So these are the things which was not mentioned in the present. Otherwise, it was a very nice presentations, almost covered everything. And I thanks all the, or congratulate all the presenters, and I thank you all the participants for a very active participations in the discussion. Thank you, everybody. And now I hand over to the Amit to continue with his NMC.
Thank you,
Answer.
sir. Well, just like to add a point to what you have said. Let me congratulate all the presenters first, that they have done a very good job of elaborately presenting every aspect. One aspect I'd like to talk about, which we are doing in Nepal, is that for the post-brachial plexus injury patient, sometimes they do not even have pain relief even after 1 year of brachial plexus injury. In those cases, DREs or tomies are very helpful. And we have been doing it, and we are getting quite a good results out of this procedure. But mind you, that is only for the pain. So coming to the menti.com questionnaire. So on the screen before you, you can see the QR code. So you can scan it and then can go to the mentimedia.com website immediately, or you can just type in www.menti.com and punch in this code. So I believe everybody must have logged in. So I will start the So here comes the first question. What is the full form of PEA? So PEA is the major component of the drug, Palmiges, which we're using. So what is the full form of PEA? And this is the same product for which the Nobel Prize laureate was actually instrumental for getting this the drug. Okay, so most of us has got it right. It is palmitol ethanolamide. Neuropathic pain is caused by all except, so this is a negative question, nerve entrapments, diabetic mellitus, alcohol, or femur fracture. That's right. Femur fracture usually does not cause neuropathic pain. Positive symptoms of neuropathic pain is well, most of us have got this right. It's paresthesia. And the fourth question for this is indication for carpal tunnel decompression is so there's a little bit of confusion I can see, but then the correct answer is all of the above. Now, a feedback for this presentation. What do you think the present webinar helped you with? So we can take as many options as possible. And then please do not forget to click on the submit your responses after you've been done. And the last feedback question, do you recommend this presentation to your peers? Well, thank you all for your active participation. Here we finish our Menti.com questionnaire here. And let me also take this opportunity to invite you for the next webinar on the same time, the next Saturday. That will be on idiopathic intracranial hypertension. This will be a combined presentation from the Nepal Society of Neurosurgeons and Ganga Institute of Ophthalmology. So we'll have almost 4 speakers talking on different aspects from ophthalmology side as well as from neurophysical side. And this will be moderated by Professor Om Krishna Malla and Dr. Patan Panta. So thank you once again. Over to the moderators and Dr. Krishna to finish the presentation. Thank you.